Hi, my name is Armen Henderson. I am an internal medicine physician in Miami, Florida, at the University of Miami, and I also run an organization here called Dade County Street Response, which I'm going to talk to you more about today. Our programs and how they're incorporated into the social safety net of Miami-Dade County. So the title of this talk is called Taking It to the Streets, Expanding Access and Adding Value to Medical Education in the Street Classroom. Okay, so I have no financial disclosures. Firstly, I want to talk about the U.S. healthcare landscape. I think it's important and how it's changed dramatically, specifically over the last, um, you know, 15 years or so, that physicians like myself are largely employed by corporations. Job-sponsored health insurance is low. The number one cause of bankruptcy in the United States is medical debt. There's a growing call for a system that encompasses everybody, like Medicare for all. There's a direct link between the social determinants of health and life expectancy, clearly defined and evident, yet no really real path to rectify. And as you can see today with the administration, the priorities for the same populations that are affected by the social determinants of health are last in place in terms of what they really care about. There's a shortage of physicians, and burnout is at an all-time high. Florida, we're in the belly of the beast. Miami is in the belly of Florida. Florida is in the United States. And so Florida definitely remains the same. Um, in Miami in particular, there are low wealth zip codes that are here that have been historically disenfranchised and divested from over the course of the last like 30 or 40 years. And because of these things, each of them has their own history, but also carries a legacy of racism and divestment that has caused a decrease in life expectancy of these zip codes. And these are also where all the marginalized communities are as well. So most of them Black, most of them immigrant, working class, etc. Social determinants of health around impact on surrounding neighborhoods. What happens is that when you divest from these communities, the populations that live there become housing insecure. So Miami is the most expensive place to rent buy a home in the United States. There's an increase in homelessness. Regardless of what you hear on TV or in the reports, homelessness is going up in Miami-Dade County. The job sector is weak. It's mostly travel and tourism or real estate, construction, etc. The large immigrant communities are constantly in limbo. There's an eroding social safety net, a climate crisis. There's a lot of things going on in Miami-Dade County in particular. And all those things are affecting people's health and well-being and ability to survive. And because of these things, I felt as though medical education must change as well. We need inclusion of extraclinical medicine. We need community outreach-based models. We need incorporation of present-day reality. And we also need connection to our patients outside of the hospital as well. So this is really where Dade County Street Response had come in for me while I was working as a medical resident in training at Jackson Memorial Hospital in Miami, Dade County. I started this organization called Dade County Street Response. It really started as like a crisis-oriented organization in which people in the community were seeing high rates of gun violence and gun-related morbidity and mortality. And people were saying that they really would like some way to respond to tools to enable them to respond to individuals that they saw literally bleeding out in the street. One of the most important things, or one of the most interesting things, I think, about Miami is that when the United States military, before they're deployed to, different countries for whatever we do there, people come to Jackson Memorial Hospital, to Miami, Florida, because they see gun violence at a higher rate than what they've ever seen, or sometimes even higher than what they see in other countries when they're deployed. And so if our military is training here because they're exposed to that type of violence and training here in Miami-Dade County, I thought it'd be a good idea to also equip, some of the citizens with the same training that, the military gets as well. And so we teach people stop the bleed. We've done we've trained thousands of people. We've had, dozens of workshops over the course of the last like 5 or 6 years. And through that work, we understood that people in these low wealth zip codes are going through crises every day. And so you have to develop programming that is tailored specifically to them and their needs. So after that, we did an incubator at Florida International University to expand our disaster relief team. And so our organization now has a crisis backing and a disaster related backing, but we have many different arms that we service within our organization. So we have street medicine, we have an urgent care, we have educational and programming tracks for medical students and medical residents. We have a community organizing team that does advocacy and public relations and events. And then again, as I said, we also have a disaster relief team, which responds to vulnerable communities before and after disasters as well. I want to say what's missing from this list, and that I think is most important for this talk, is our Freedom House Mobile Crisis team, which I'll talk more about a little later as well. So Dade County Street Response has integration within University of Miami and Jackson Memorial Hospital. We have formal MOUs between multiple departments at these anchor and private institutions because I'm affiliated with them as well, which made it very easy. We're also sponsored by the Department of Health. And it seems as though other institutions across the country are also very interested in this type of partnership. I think what's most important to mention for the purposes of this talk is that universities and anchor institutions are very important to the communities that we serve. They get a lot of money, they have a lot of support, they have a research backing, and so it is very important for us to get with those organizations to make sure that they understand the importance of the work that we're doing in the community and on the street, specifically when it comes to mobile crisis. If not, then we allow the institution of policing to basically usurp our work and our ability to remain, outside of those institutions that kind of corrupt the work that we're doing. So I'll talk more about that a little in just a minute. Our priorities at Dade County Street Response are programming, education, and then research, not in any other order. We want to make sure that the people that we're serving understand that the first and primary reason that we're there is to serve their needs, and then the other things are ancillary. Now, they're ancillary, but it doesn't mean that they're not important. Education is definitely important. We want to train the next cohort or cadre of medical professionals to practice medicine and to come up with programs and to support programs like the one that we're putting forth. But also research is also important because data is important, and that's what institutions where institutions come in and kind of help us out. But also because if we're trying to vie for federal funding that other reputable organizations that are very organized are trying to vie for as well, then we need to do the research that shows that our methods, that our programs are better and more cost effective as well. So first, I'm going to start going through our teams in particular, and I'm going to start with the street medicine team. The street medicine team operates 7 days a week. I think two or 3 weeks ago, we went on our 200th street run. So what that means is that the street team itself goes out in person with a large group of individuals that include medical students, doctors, case managers, psychiatrists, and other community health workers to service the needs of those that are unsheltered. So when I say that we went on our 200 street run, what that means is that we've gone out 200 weeks concurrently over the last couple of years. And so that's a big milestone. What that also means is that for people who don't have access to internet or normal services, housing, etc., that are always in flux, always being criminalized for camping and things of that nature, as we've seen in Florida and all across the country, the criminalization of homelessness. Consistency of being in the same area, I think, is important. It's very, very important for service delivery, so that even if people don't have access to phones or internet, they know exactly where to find us. And we've been there for 200 weeks in a row. So far, this number is higher now. It's about 1,600 patients concurrently, in which we do longitudinal care coordination, research development, advocacy, mental health care, specifically for those that are living on the street. Street medicine is a new field of medicine that has come about over the last couple of years. CMS just created a billing code for us, which tells you that it's very, very new. People are not really billing. It's very big in California. And we're so lucky to have one of the largest and most complex street medicine teams in the country. And it was created due to the lack of coordination of services amongst the unsheltered. And so Our street medicine team started because during COVID-19, I was doing street medicine like work, and a student that was at University of Miami, who's now graduated, he's at UCLA now, a medical student was approached me and said, "Hey, I've been working on this whole background and theory around street medicine, and I want to bring the infrastructure to the work that you're already doing on the ground." That was surveyed, and some of the documentaries that are currently on Netflix and things of that nature, where they were, basically they got the work that we were doing during COVID on video, um, and uh, and so I was like, cool, let's do it. And so that was the formation of our street medicine team. I was already doing it, and then the student brought infrastructure to it as well. So street medicine, if I had to like sum it up, it's really just go to the people. It's bringing the services outside of the hospital and bringing them directly to the street. And I think that this really encompasses what's really important in our background of Dade County Street Response, is that we're not waiting for anchor institutions or private institutions to come and figure out that research is important, and this is why they want to bring the service. We're going to the people, and people are telling us what's important, and we're bringing that to people as well. And so these are some of the pictures of what we do on the street. We don't go out in cars; we go out on foot, in book bags, and students are there, and where we have our internet, our medical record, our supplies that we're bringing directly to people who need it most, which are those that live on the street. And we're not just bringing medical care. I would say one of the most important things that we're bringing are the social services, helping people who qualify for disability or Social Security. We're helping them apply for those things, and who may qualify for housing or may need to be in a shelter, who may need to go into a long-term facility because of their chronic medical conditions. We're bringing those things and the internet and the ability to apply for those things directly to individuals that need it most. So we need street medicine in the United States because there's barriers to access. People who live on the street have abysmal outcomes. I think they die sometimes 25 to 30 years earlier than individuals who have houses. High costs associated with individuals living on the street, because these are the highest utilizers of the emergency room and healthcare systems that are close by, and there are also huge cracks in existing healthcare services. We do good work. As I said, we collect data. We've published a lot of papers on our work. And so we've published, specifically around how we're managing chronic diseases on the street. And I think that this is going to be pivotal to the funding of our work in the future. One of the challenges that we face is just gaining people's trust, because they've been so like left behind, and you'd be surprised at how many people feed on unsheltered people for their information and things of that nature. And so our job is really to prove that we are there only to serve their needs and no one else. And so this is a summary of our engagement approach. We contact them, we develop a relationship, we evaluate them, we do care provision, and then we follow up. And I think it's important for us to spend so much time within street medicine, because these foundations affect these principles are the foundation for our entire organization as well. We do a trauma-informed approach, and people can consult us from inside the hospital and outside of the hospital. And I think one of the most important things is that we have this community resource list that we're able to get people access to the things that they need. Next, I'll talk about the disaster relief team. It is a foundation and framework of all of the work that we do as well. The disaster relief team was started because Miami has hurricanes every year, and after the wake of Hurricane Katrina, we saw that the federal government, the local government, the state government does an abysmal job of taking care of poor and vulnerable communities, specifically during disasters. And so this was the reason why we started our disaster relief team. We are in a community of disaster relief organizations that also provide care to individuals, and Dade County Street Response is the medical arm of that coalition of organizations called the Community Emergency Operations Center. And if you want to see more about the guide that we have, you can use the link there, type it in with the punctuation there, bit.ly / DCSR GUIDE guide. Okay. This work, again, was something that was started as an incubator at Florida International University. Student who's pictured here, Lena Carlton, in which the community directly asked for medical professionals to respond to them and to be there for them specifically during disaster. And this was a climate and health fellowship I did as a result of the work that we're doing. So I'm actually an expert in disaster relief and crisis care as a physician as well. We also have a University of Miami Laboratory for Integrative Knowledge, in which we have different people from different specialties come together that are outside of medicine to solve and to educate people about climate change and the disasters that people find themselves in related to disasters as well. So it's people from all the schools of development in that. And we have a climate and racial justice talk series that featured Harriet Washington, who is a prolific author that writes a lot about environmental justice work, etc. Outside of that, we have our urgent care. Our urgent care is open 3 days a week. We partner with Direct Relief and AmeriCares to provide our medications. We are part of the Florida Association for Freedom Charitable Clinics. And basically, the name of the clinic is called Doctors Within Borders. And it's a play on Doctors Without Borders, meaning that you don't have to leave the United States borders to see people living in third world countries. You can literally go down the street in any urban neighborhood and see people living in decay, similar to third world countries. This is our clinic space. It's disaster proof. It's made out of shipping containers, and it's located at the Freedom House Lab, which is where our Community Emergency Operations Center partners for disaster relief are also co-located as well. The other projects that Dade County Street Response is involved in particular, is this alternative to 911 mental health mobile crisis line. And then we also have a community-based trauma recovery center as well. So I'm going to talk a little bit more about the mobile crisis line. So our mobile crisis line was started in coalition with three other organizations. One is an organization called Circle of Brotherhood. They do community violence intervention. Another organization is called Touch Miami with Love. They do children's and youth activation and after-school programming and education for youth. And then the other organization is Dream Defenders. They're a national now organization that focuses on justice and anti-police or activities and programming that are outside of police and prison institutions as a means of abolition. And so this alternative to 911 mobile crisis team was something that was started about 2.5 years ago. We had a small grant where we were able to hire up to, I think we had 8 or 9 people on our team. We were open 6 days a week for 12-hour shifts. And our primary goal was to respond to mental health and wellness checks in the community so that the police did not have to. And there's emphasis on so that the police did not have to, because when the police do show up, research shows that they are 16 to 17 times more likely to show up and actually kill you. And it doesn't matter whether or not you're black or white or poor. It's just they're just not equipped to handle mental health crises in particular. And they have guns and they escalate. They're just not trained. And so escalation happens with them, and so does morbidity and mortality. And so we thought we could do it at a fraction of a cost using the medical and the social, expertise that we have in the community. And it was a very successful project that has since lost its funding. People in the Liberties, we were only in one area, one neighborhood in Miami-Dade County in a 5-mile radius. And people could get access to our services by calling 1-866-SAFE-MIA. Now, this number still works. It comes directly to my phone right now as we are trying to revamp our program. Presently, we're in the process of signing a contract with a pharmaceutical company that is now going to sponsor, and this is big news. They're going to sponsor and help us relaunch our program and to research it on a grand scale so that we're able to show that, number one, we decrease morbidity and mortality related to if we show up instead of the police showing up, but also this is an economically viable option that should solely live outside of the police. And so we are so lucky and so excited to revamp this program, because in our last impact report that basically showed what we actually were doing on a small scale in Liberty City with the small money that we had, we actually were able to de-escalate 100% of the calls that we received. And we received about 200 calls over the course of a year. Or 300 calls over multiple calls, but we went to 300 specific visits, we were able to de-escalate all of them. Some, some people had weapons, some people were suicidal. These are individuals where, normally as a medical professional, I'd be told to Baker Act these individuals, which is like a involuntary hold, basically putting them in hospital jail. And so this is what we were able to do without having to, put people at risk of jail or put people at risk of getting shot and killed, or tased, or held indefinitely or, involuntarily in the hospital. So outside of decreasing the amount of police intervention, the alternative to mobile crisis team that we have also significantly decreases involuntary holds, or what we call a Baker Act in Florida. And research shows actually that 50% of the hundreds of thousands of people that are involuntarily held in the state of Florida, 50 to 60% of those individuals, of those involuntary holds, are activated by police. So police can also Baker Act individuals as well. And so we find this very problematic, especially given that they're not medical professionals. This is something that I feel as though doctors rarely do. And yet the majority of individuals that are activated for involuntary holds in the state of Florida, we're talking about, tens of thousands of people are involuntary held only because a police officer said they should be. And so we find it's very problematic. They weaponize this against people who are unsheltered. They weaponize this against people who, who are black and brown and who they're ill-equipped to handle. And probably, I would hazard to say that the people who they don't Baker Act, they probably shoot them, which is what the data shows as well. So our alternative to 911 mobile crisis line is one of our most impactful and radical programs. And it was aptly named after Freedom House, which is the mobile crisis team, or the start of what we call EMS, emergency mobile services, in America. Was started as a an organization in Pittsburgh, in which individuals in Pittsburgh were finding that police didn't know how to transport people to the hospital. And so when they were throwing people who were sick or injured in the back of a police hearse, people were dying. And so people in Pittsburgh were just like, we're tired of this. We want to get together with the University of Pittsburgh, and we want the physicians there to train us how to deliver emergency medical services to those that need critical care and need transport to the hospital. And so it was called Freedom House. There's a documentary about it. And physicians and medical professionals from the University of Pittsburgh taught individuals from the community, just random individuals who were black, how to do intubation, how to start IV lines. And they've seen a significant decrease, a significant drop in the amount of morbidity and mortality, death and destruction of individuals that they were transporting in hospitals, solely because of this program in Pittsburgh. And it was so well received in Pittsburgh that the United States expanded to what we call EMS based on this system. And so you should thank people in Pittsburgh and University of Pittsburgh for starting this program, which is a direct result of Black Panthers and the University of Pittsburgh and medical professionals. So we named it that aptly after that program. So that's very important. Look for great updates that we have on our social media at Dade CSR, at Instagram, or on our website, www.dadecounty-street-response.com, for us to announce that large grant and the relaunching of our program there as well. So with that being said, we also have education and programming tracks. I'm going to glaze over this really fast. For medical students and residents, and we actually designed a curriculum because we don't just feel that this is something that like a program that people should just have access to in the community. We feel like that this is also something that we should teach the next generation of medical professionals about why it's important, and so that this can become a viable program that people say that, okay, when I graduate and I become a doctor, I want to do mobile crisis, or I want to open up a free urgent care, or I want to open up a food pharmacy program, or I want to start a disaster relief team. And so we educate people about our programs, and this is a part of their medical education officially, as I am an associate professor of medicine at the University of Miami as well. And so the steps that we went into designing our curriculum was that we incorporate history. We tell the truth. We tell a story, and we bring in historical context. We do not shy away from the racist and capitalist history that is of the United States, and we think it's important because it leads to why we're developing the programs that we do. And at a time where we're banning books and changing history, we think that history is very, very important in this endeavor. The other thing that we do is we establish very deep community connections We don't just swoop in and say, oh, these are the services that we think people should provide. We listen to the community and ask them, hey, is this something that you think would be important? Or, hey, I heard that you thought that, that you wanted Stop the Bleed in the community. We want to develop programming around Stop the Bleed, because so we can help you respond to your loved ones and people who you care about in the community who are shot because you're experiencing high rates of gun violence. And these are the type of community connections that continue to help us, have the community mold our students and residents and people that are in our education tracks. This is how they're allowed access to the community as well, because we've established this deep community connection. And we take it very seriously as well. And so these are some of the media aspects that we've been involved in. As you can see, the documentary that I said that I was profiled in for during COVID-19 is currently on Netflix. It's called Convergence. You can watch it. It was nominated for an Oscar. It did not win, but it is definitely an eye-opening documentary, and the impetus for why we started the street medicine team as well. We also review the basics, though. People are like, oh, how can you do these programs that are connected to the community and still teach people? Students and residents and medical professionals, they still get the same education as they would inside the hospital as well, because it's very easy to input the basics into almost every encounter that we're doing with people who need social services as well. So people actually get the actual bread and butter medical education, as we say. The other learning lessons that I think are important that can't be taught in a classroom setting or behind the hospital doors are humility, for sure, intersection between class and race, systemic racism, criminal injustice, environmental injustice, the art of storytelling, everything that they don't tell you about in the classroom. These are the things that we're talking about: the politics of homelessness, the art of case management. What is it? Why is it important? And we also do media training as well. Our other learning objectives is that people learn violence de-escalation, which is the main tenet of our alternative to 911 line, and the main tenet of community violence intervention is that we can de-escalate our own crises, and we teach students how to de-escalate these things as well. We don't have to call the police for every time someone gets upset or every time we need some media or we need something mediated. We can mediate our own conflicts, and we should not depend on people who come up and show up and increase the morbidity and mortality by using their guns to show up and help us mediate our conflicts. It just doesn't make sense. And so we teach people and students how to do violence de-escalation, but people also learn wound care. They learn the management of chronic conditions and people experiencing homelessness. And I also want to say that students and medical residents are not the only people who are learning these things. We also do community workshops. We also hire people from the community who are also learning all these things too, and learning alongside residents and medical students as well. We're there for the long run. We don't swoop in and leave the community high and dry. Our program, people expect us to be there for the long run, and they know that we are a vital aspect of the safety net. We are a safety net to the safety net. And so as that important partnership, we want people to know that we are there for the long run. As I said, we had our 200th street run, which means that we were out there in the street at the same place on every Saturday for 200 weeks straight. So that's very important for us as well. We also practice participatory research. We do not do research that is not in the benefit of the populations that we're serving. We do not do research to extract data and only to solely, garner federal government dollars and grant contracts, et cetera, and accolades. We share the research that we do with the community, and our community directly, and the research that we do directly benefits the community that we serve. If we get a grant from the federal government, we put directly in the grant that we want to provide patient grants, that we want to give people money for their time. We want to give people money for access to the data we're able to extract from them if that's the case. And we explain to them exactly what we're doing. And at the end of the data project, we present it to them in layman's terms as well. That is the sole tenet of participatory research. But we also acclimate and orient students and residents. I also want to say that this is also one of the reasons why a lot of students and residents join our team, because they get research that they need in order to progress to the next level in their training as well. But we also acclimate and orient students and residents. We do constant orientation. We do not just send students out there, residents out there into the abyss and say, oh, go ahead, de-escalate the crisis. We give them constant workshops. They're always in the community. They're in and of the community at every point in time that they're able to be. That we always leave room for questions, and we allow them to come to conclusions about the experience as well. At the end of the experience, they're saying, wow, America's messed up. We need alternative systems outside of police and prisons and hospital doors, et cetera, that go directly to people. And I don't just say that. I let people come to those conclusions themselves, and they do. And we also allow student and resident input modification. If there's something that they don't like or that they feel unsafe in, then we allow them to tell us how we can change it. And we take that feedback very seriously as well. So to recap, our curriculum design is that we incorporate history, we tell the truth, we establish relationships, we review the basics, we learn new tricks, we are there for the long run, we do participatory research, we do constant acclimation, and we also allow modification and resident and student input as well. And so with that, I'll close. Money has been one of the most important and one of the hardest things that we've been able to garner access to. Right now, as I'm closing, we have some alternative ways to do revenue generating structures. We're actually selling our data to the hospital. We're showing them that we save the hospital money. We're not selling it to them. We're in a data sharing project with them. And we're showing them that because of our services, we save the social safety net and the county and therefore taxpayers' dollars money. And in response, we're asking for a percentage of that back to continue to run our programming. But we're also looking at, developing land that we have into low-income housing, which our patients need for sure in a place like Miami. And we're using the revenue from that land development to fund our programming as well. So we're looking at revenue structures that are outside of just billing Medicare and Medicaid as well. So with that, I will close. Thank you so much for your time today. And I look forward to hearing from you soon. If there are any inquiries or any people who have any questions about the work that we do, you can email us directly at admin@DadeCountyStreetResponse.org. Admin, ADMIN, at Dade, DADE, County, COUNTY, Street, Response, RESPONSE.org. I'm Armen Henderson, and thank you so much for your time today.